Okay, guys, so this is the third part of the lecture series. This is the vascular lecture. So starting off, we're going to do a little bit of carotid Doppler. Carotid Doppler is something that either you have a lot of experience with or you tend to have no experience with, depending on where you where you're training in residency. Certain programs dominate this, and they do all of them ad nauseum, where you're doing like 100 of these things a day and you hate them, but at least you know what's going on with them. And then there are certain programs that don't do them at all, that a radiologist has decided to teach a cardiologist or vascular surgeon or somebody else how to do them, because the true specialty of a radiologist is teaching other specialties how to do that radiologist's job. So I'm going to try to give you some general principles, and then we'll talk about some gamesmanship as well. So here's a first case. It is we've got a waveform here. We've got it labeled as the ICA mid portion. A peak systolic velocity is given, and then we've got a ratio of the internal carotid and common carotid. A couple of things I want to point out. Notice how brisk this upstroke is. That's normal. That's what that's supposed to look like. When that's not there, that's abnormal. Anytime that a number is provided on the question, like as far as velocity, it's probably going to lean you towards a stenosis question. Now that'll be obvious once you see your choices, although they could throw some other random stuff in there. So basic idea, and this is just bread and butter carotid Doppler if you haven't done it before. You've got your bifurcation, and readings are done here, 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 here. You can't measure inside the skull. That's pretty difficult. But they do a bunch of different measurements there. And what you're looking at is the velocity of blood, and you'd assume that it would be normal and continuous through the entire area there. Now, if you have an area of stenosis, just like anywhere else in the body, you're going to get a jet as the blood moves through that particular region. The velocity at that area is going to be increased. So measured here might be similar to here, but then when you measure it here, it's going to be increased. And then you measure it here, you might get a dampening of the waveform. That's the general idea. And that somebody along the line has done a paper that said that a certain velocity increase is equal to a certain degree of stenosis, and that is a testable number. And if you've done a bunch of these, and you probably have it memorized, basically less than 125 centimeters per second, peak systolic velocity. Okay, so here's a few, I'll get to that in a second. Peak systolic velocity, less than 50%, is considered normal. In other words, most people will tell you that less than 50% stenosis does not create a hemodynamically significant number. So in other words, you can't say that like less than 115 equals 45% and less than 105 equals 30%. It doesn't work like that. Less than 50% is basically all you can tell, and there will be a variety of ways that you could write that fact into a test question to make it sneaky. Now, there is a paper out there that says that you can distinguish between less than 15% stenosis and between 16 and 49% stenosis based on spectral broadening. I think that's a bunch of baloney, and I also don't think that it is, because that spectral broadening is so tech dependent, it's really silly to go by that and be able to tell a difference. And it's also silly for a second reason, which is the classic thing that radiologists do, where they obsess over shit that's irrelevant to the surgeon. Like, who's the person that's actually ordering this? It's two different scenarios. You have family medicine or Herta Brewy. Anytime you have requisition that says family medicine heard at Brewy, you can go ahead and dictate a normal exam. They're always, or it'll be on the other side. It'll be severe high-grade stenosis on the other side that they didn't hear the Brewy, because physical exam is a bunch of bullshit, especially when it's done by family medicine people. Number 2 is that it's done by a surgeon, either vascular or neurosurgery, who wants to cut a plaque out of somebody's neck. And they're not going to operate on somebody because they're at 15% stenosis versus 16% stenosis. So developing criteria that can tell the difference between those two based on spectral broadening, something that's extremely variable between techs, is really, really dumb. Of course, the real reason that you write a paper like that is so you can get promoted in academics. I digress. The thing to remember here, I'll back up. The thing to remember is less than 50% stenosis is normal. You can't tell the difference. And some people will call this mild or normal. Between 50 and 69% is moderate, and greater than 70 is severe. And then there's this ratio where you're basically comparing the velocity in the common carotid to the ICA. This is used more as a secondary thing. I would lean on the peak systolic velocity. Now here's a second trick that you could end up with. There's a couple of different tricks with regard to numbers. So here would be some fuckery that you might want to watch out for. These numbers are in centimeters per second, this number, okay? Not meters per second, not millimeters per second, not millimeters per minute, centimeters per second. So there could be a degree of fuckery that occurs with those numbers in a deliberate attempt to trick you. The other thing is that this measurement is a peak systolic velocity. It's not a mean systolic. You don't care about the average. You want to know what the highest part of the jet is. So it's peak systolic velocity. So that could be ways that could, multiple choice could show some trickery there. All right, next case. Notice that this is labeled. The other one wasn't labeled. Labeling sometimes cues you into what they're trying to think. And then the finding on the exam here is this delayed upstroke. Remember I said before it's supposed to go like basically straight up like that? This is delayed upstroke. So this is a tardus parvus waveform. And basically, just like anywhere else in the body, like we're doing a hepatic Doppler or whatever, tardus parvus is essentially telling you that there's a severe stenosis proximal to the point of sampling. So if we've got our bifurcation here, and we're measuring here with a tardus parvus waveform, anywhere proximal to that could have an area of severe stenosis. Now, if you'd given you multiple waveforms up and down, you'd be able to sort of tell where that was at, but that's deliberately not shown here. So the point is that aortic valve stenosis could look like this, or you could have, because we're on the right side, you could have innominate stenosis, anything proximal to that. The difference is that if they were going to show you a valvular stenosis, I think that they would show you both the right and the left common. So, right, exactly. And also, yeah, here's a thing too that I didn't mention. This is the common, not the internal carotid. So, we're measuring here. So that is a trick also that's telling you that this is a really central stenosis. So this is going to occur either at the valve or innominate since it's on the right. But I think if it was valvular, they would show it both sides. So if you got both of them with tardus parvus, it's going to be a valve, aortic stenosis. Otherwise, you can just assume that they mean it's going to have a laterality to it. So here we go. Here is a classic. So anytime you see vertebral artery in a Doppler question on multiple choice, there's only one answer. And it's this. It's subclavian stele. And you've got reversal here. But without even seeing that, without even seeing that. So you know that when I say vertebral artery Doppler, you say subclavian steal. That's the only thing that they're possibly going to show. I say vertebral artery Doppler, you say subclavian steal. So let's just go through it really fast. We've got delayed upstroke and our right subclavian, which is telling you there's an area of severe stenosis there. Left side vertebral, that's normal. Right-sided vertebral is having reversed flow. So that's just the general idea, is that this is a normal side over here. You've got an area of high-grade stenosis. So this part of the body over here still needs blood, and because of that, it's basically creating where it's stealing. The subclavian is stealing out of the vertebral. During systole and then diastole, it's passively sort of going back up. So what's the most common cause? Don't overthink that. It's cheeseburgers. What are some rarer causes? This is probably more testable. Vasculitis, radiation, arterial shunting that would occur with congenital heart disease. Again, so a bilateral Doppler, so when you see bilateral Dopplers that have the same waveform, they could show you bilaterals with one being normal and one being abnormal, but when you've got bilaterals with the same waveform, think about the valve. So we already had an aortic stenosis case, or what could have been an aortic stenosis case with a dampened waveform. This here is showing reversal of diastolic flow bilaterally. So this is aortic regurg or valvular incompetence. The other thing that can happen at the valve. So are there ways you can tell the internal carotid versus the external carotid apart? Yes. They operate very differently. The way to think about it is that your brain is always on, requires continuous blood flow, regardless of what you're doing. If you're sitting down or you're sleeping or whatever, your brain is never off. So it requires continuous diastolic flow, and the diastolic flow should never go to baseline. And because it's always on, it should be easy to get blood flow to it, so it's going to have a low resistance waveform. Now contrast that to skeletal muscle, including those muscles in your face. They are on when they need to be on. So if you're talking and you're laughing or you're lifting weights or whatever, that kind of stuff, then the resistance waveform will change. But at baseline, you've got a high resistance waveform because you're not using them. Diastolic flow is not continuous. It will return totally to baseline. So that's the main principle. The secondary thing is that external carotid has a whole bunch of branches. So if you were trying to tell the difference between the two of them while you're imaging, the one that's branching over and over and over again is the external carotid. And you may remember there's a mnemonic for that. Some administrators like fucking over poor medical students. There's another thing you can do, which is called a temporal tap. Basically, you find the temporal branch of the external carotid, which is on the temple, and you tap on that, and that creates some vibration in the waveform, and then you can see that as you're imaging down in the neck. So you're actually manually taking your finger and tapping, temporal tap, and you'll see that labeled sometimes as TT with an arrow. So what does brain death look like on carotid ultrasound? In Europe, I've been told that they do actually do brain death studies occasionally with ultrasound, carotid ultrasound, just like the nuclear medicine brain death study that we have here in the States, which basically shows no blood flow through the internal carotid. It's all external carotid. because when you die, your brain turns off, and all those things I said about the brain being continuously on are no longer true. So you transition to a high velocity or high resistance waveform. You lose your diastolic flow. It's not continuous anymore. It returns to the baseline. So you basically end up creating the external carotid, end up looking like the internal carotid, and then eventually the external carotid will have an even lesser resistance waveform than the internal carotid when it's very bad. But basically, the bottom line is loss of diastolic flow equals a brain that's off. High resistance waveform in the internal carotid means something terrible has happened. What about aneurysms? Can you tell what's the velocity changes in the waveform when you've got an intracranial aneurysm, like a Berry aneurysm? You can't tell. There's no difference. So if you would be asked that, there's no way to tell the difference. You can't detect aneurysms in the brain with carotid Doppler. So this is sort of something that we talked about earlier. We've got common carotid, not internal carotid, common carotid that looks just like the external carotid. So it's been externalized and its waveform. It's high resistance. The diastolic flow is pretty much zero at diastole, which is for diastolic flow. It's baseline. What can make this happen? So basically, occlusion of the internal carotid will make that happen. So it basically turns your common carotid into your external carotid. Note the lack of diastolic flow. All right, we've concluded the ultrasound stuff. We're going to move on to some other things. So we've got two different dissection flaps, orange and yellow here. And the point of the case is to distinguish between the Stanford A and the Stanford B dissection. So Stanford A is a surgical type of dissection that occurs proximal to the takeoff of the left subclavian. That's the demarcation point. Anything before the takeoff of the left subclavian is a Stanford A. Anything that occurs after that is a Stanford B. If it involves the aorta, both proximal and distal to the takeoff, it's still a Stanford A. So anything that you see happening prior to the takeoff of the left subclavian makes it a Stanford A, regardless of what's happening distally down in the aorta. It doesn't matter. The only thing you need to know is there a dissection flap in the aorta proximal to the left takeoff of the left subclavian? If the answer is yes, you have a Stanford A. Stanford A is surgical, because that's bad. You can imagine you don't want that dissection extending down into the aortic valve. That would be bad. Stanford B is typically managed medically unless there is end organ ischemia, like the dissection flap is taken out one of the renal arteries or something like that. Then they have to go in there and intervene. But otherwise, as long as you're perfusing your organs normally, that they will watch them. Okay. So which one's true and which one's false? And what I mean by that is, which one's the true lumen, which one's the false lumen? So here's some general tips on that. The larger of the two is the false lumen. And the way to remember that is that it doesn't have the normal layers that the true lumen would have. So it's more it's more flexible. It's going to distend more easily because it's not the normal coating that the artery has. Where, if you would happen to see intimal calcifications, where would they be? Well, they would be in the true lumen, because that's where, when you have atherosclerotic calcification, remember, so you got blood, you got cheeseburgers going through the artery, and they're depositing on the inside of the vessel, on the inside of the wall. That's where these plaques are building up, right? So you would expect that inside of the true lumen. And then where does the left renal artery originate from? The true lumen or the false lumen? This is a generalization. And the answer is that it's off the false lumen. Now, why did I mention the left renal artery and not the right renal artery, the celiac or the SMA? Because everything else tends to come off the true lumen. That left renal artery, for whatever reason, just the way dissection flaps happen to occur, tends to always be at the origin. The left renal artery tends to come off the false lumen. So just remember that one, and all the other ones are coming off the true. So here we have a neck, MRI of the neck. Here's a zoom up on the finding. So this is the so-called crescent sign of arterial dissection. Basically, what you're seeing here is subacute blood, and to maximize detection of that, you want to get a fat-saturated T1 image. The blood is the blood that's within the false lumen. This is more of a neuro thing, but I figured this was a good time to at least bring it up since we are talking about dissection. Yes, acute intramural hematoma would look similar because blood looks like blood, but if you Google crescent sign neck dissection, or crescent sign neck or neuro or something like that, it's dissection is going to come up first. So if you see that, think dissection. Another way dissection can be shown is with angio. This is the so-called floating viscera sign, where you've got the catheter within the true lumen, and it looks like the mesenteric vessels are just floating, like they're coming off of nowhere, supposedly floating. Now, what you probably wouldn't see, because the catheter is in the true lumen, probably would not see opacification of the left renal artery. Because remember, that comes off the false. Usually, not always. So here's the next case. We'll do a zoom up. Well, we've got, so this is a non-contrasted study, and the image, this one, it's just windowed more at like a liver window or a subdural blood window. Take a closer look here. Notice that there's this hyperdense area right here, which is abnormal. If you haven't seen this before, now you have. This is acute intramural hematoma. Basically what this is rupture of the vasa vasorum. You may remember those were like the little vessels that are within the vessel without a discrete intimal tear. And this is the reason that you do a non-con on the dissection protocol. Most places, when they set up their dissection protocols, do a non-contrasted followed by a contrasted study. And the reason that non-con is included is so you can pick up intramural hematoma. This would be like somebody, a chest pain order out of the ER. You would include a non-con. You wouldn't just go straight to a contrasted, because then you could miss that. How do you distinguish between this finding and a thrombosed dissection? Dissections tend to spiral around, where you've got your false lumen and your true lumen. There tends to be a spiraling as you move downward, whereas the intramural hematoma tends to not spiral. So this is another this versus that, and it's to point out that just like dissection, which has a type A and a type B, you can grade intramural hematoma similar, where you have intramural hematoma here versus intramural hematoma here. Notice that it's here too, but that doesn't matter, right? Because this is proximal to the takeoff of the left subclavian. That makes it a type A, And because we're assuming that they're not showing us that there is blood here, that this is a type B. So what are some of the mortality predictors? Bigger, so if you have an aneurysm, that's obviously you've weakened the wall here, so it's more likely to rupture. The thickness of the hemorrhage, the presence of a pericardial effusion, which means it's bleeding down into the heart. Here's a good question. What is the strongest predictor for progression to dissection? So remember I said that intramural hematomas are just bleeding within the vessel wall without a tear. So what would be the strongest predictor for progression to a tear? And that would be size. So it's one of those like Laplace law things where, bigger, more pressure, more likely to rupture. So remember that if you've already got a stretched wall and then you've got bleeding within that stretched wall, that it's more likely to tear, which just makes sense. So there are 3 acute aortic syndromes: penetrating ulcer, dissection, and intramural hematoma. Probably the most testable point about these 3 is what is the primary cause. Atherosclerosis is the most common cause for penetrating ulcers. This makes sense if you've seen a penetrating ulcer. They tend to look like they've got plaque and calcified disease and those kinds of things. So just think in your mind of that picture of a penetrating ulcer. That will help you get the answer. Just think about like an inflammatory process eating through the wall of the vessel. Dissection, on the other hand, is from hypertension. And the way that I like to think about this is a very high pressure pulsation, like slamming into the aorta over and over and over again, and that shear force actually causing a tear. Calcified intimal calcifications, like the atherosclerotic calcifications along the intima, are actually said to be protective for aortic dissection. You can think about that as sort of making a wall or a shield on the inside of the intima. Now, obviously that causes its own set of problems. And then acute intramural hematoma is also from hypertension, and remember this is a hemorrhage into the vasa vasorum that are inside of the wall. I like to think about this the same way as dissection, where you've got this like tidal wave jet pulsating into the intimal wall, and that's actually it's just beating it up like over and over and over again. And even though it's not actually tearing it, that force of like the trauma of like getting slammed into is what's causing that intramural hematoma within the wall. So what about this guy? This is obviously in the setting of trauma. We've got a contrasted CT. Now, anytime that there's contrast on board and they're showing you the chest, if you're not sure, it's helpful to try to figure out whether or not the contrast bolus is timed to the pulmonary artery or the aorta, or if it just seems to be the regular run-of-the-mill contrasted CT, because it can help narrow where you're looking. This is obviously a trauma protocol where you've timed the bolus of contrast to the aorta, because that's the thing you're caring about. And on the axial image, you can see that there's this sort of jet of contrast here that looks like it's outside the wall of the lumen. And then on the sagittal, there's this collared appearance where it's here and here. So this is a transection. Now here is a traumatic pseudoaneurysm versus a transection. I put these side by side because I want to point out that they're occurring at the same location, where you have the ductus, which is now scarred down, basically creates a ligament there that tethers the aorta at that point. So you have your high-speed collision, everything in the chest moves except for the part that's tethered down, and that's where you have your injury. So there's 3 basic spots that you have traumatic injury to the aorta in the setting of a high-speed trauma, and it's all the same principle, which is this tethering principle. So the isthmus, right here where the ductus was, and now it's created a ligament, there's tethering here. There's tethering right at the root of the aorta where it's attached to the heart, and then there's tethering by the diaphragm here. So you'll read some places that this is actually the most common place for injury. The problem is that when you have an injury here, that you die. You never see them in the scanner because they never make it to the scanner. Most places will tell you that the isthmus or the area of the ductus is the most common location. And then the third most common is right at the diaphragmatic hiatus. So this is a stent graft study. If you've seen a stent graft study done, it's typically done with 3 phases. You've got a pre-contrast, then you have an arterial phase where you pacify the stent graft, and then you have a delay. And the reason you're doing that, well, there's 2 things you're looking for. One is the sac size, because sac size matters. You want to see if it's getting smaller, staying the same, or getting larger. If it's getting larger, that should tip you off that there may be an endoleak, which is the second thing you're looking for. And for me, I think the easiest way to tell whether or not there's an endoleak or not is to compare the density within the sac on the pre-contrast to the delayed. And if it's increasing, that means that you're leaking contrast. So in this case, we can see that there's contrast here on the delayed that wasn't present before. So this is an endoleak. Now there's 4 or 5 different types of endoleaks, 4 that are worth knowing. A type 1, which is contrast leaking in from either the top or the bottom of the sac around the graft, where you can see that the graft was placed too short. It should probably have been placed down here. So we didn't cover the entire sac, and as a result, blood is leaking in from the sac in from the aorta into the sac here. If it's at the top, they call it a type 1A. If it's at the bottom, they'll call it type 1B, B for bottom. Type 2 is if you've got a feeding vessel that's feeding the sac. This is the most common subtype. What would be an example of a feeding vessel would be the IMA or a lumbar, but it can be anything. Those are just the most common. Type 3 is if you've had fracture of the graft itself or the components disengage from each other. The most common situation where I've seen this is when you have an iliac part, and then you've got an aortic part, and the iliac part disengages from the aortic part, and then it's like falling apart, and then you have sac sizes increasing, and you've got contrast outside of that there. And type 4 is the pore, 4 pore, and this is really historical, but the material that they used to make these things out of had some element of porosity, and they would leak. There is a mysterious type 5, which is endotension, which may be just pulsation from inside of the aorta. These are actually real, but are unlikely to show up on the test because their existence is somewhat controversial. The things to know are the types. You should know 1, 2, 3, and 4. 1 is it's not covered, 2 is a feeding vessel, 3 is they're disengaging or breaking, and 4 is the pore. You need to know that type 2 is the most common, and the most common feeding vessels are the IMA and the lumbar. And then you need to know that type 1 and type 3 are often fixed earlier because they tend to be higher pressure, where you actually have rapid blood inflow from the aorta. Type 2s they'll watch sometimes. Okay, so this is a compare and contrast of 2 similar pathologies. There are only a few true Aunt Minnies when it comes to vascular imaging. This is one of them, which is the tulip-shaped aorta, where you've got ectasia of the annulus and the aortic root. So like this part here is bigger than that part here. It's usually the other way around when you see aortic aneurysms. And this is an Aunt Minnie from Marfan's, which you may remember is a defect in this fibrillin gene, which is part of like how your collagen works. Now there's another entity that is similar to Marfan's, but more severe, called Loeys-Dietz. And it's an even more severe form of Marfan's. They're even more prone to aneurysms and ruptures. And they get this unique finding, which is very tortuous vertebral arteries and the vessels in the neck. I like to refer to this as the roller coaster sign or the loop-de-loop sign, where you actually have a vessel that's so tortuous that it's turning around like that. I've only seen this with Loeys-Dietz. It is an uncommon entity. The 4 or 5 cases of it that I've seen tend to have similar findings, a lot of tortuosity in the neck vessels. So Marfan's has this very classic tulip bulb appearance. Annular aortic ectasia is a buzzword which describes the type of aneurysmal morphology. The dilation of the root leads to valvular problems, specifically valvular insufficiency. Obviously, it wouldn't be stenosis, right? Because you're stretching it apart. They have to repair these things around 5.5 centimeters earlier than they normally repair them around 6. But for Marfan's, they'll repair them earlier because they're at a high rate for rupture and dissection. Loeys-Dietz is, think about this like Marfan's on steroids. And like I said, very twisty and tortuous neck vessels. This is another Aunt Minnie, which is the unilateral swollen leg, especially the left side. When you have a left-sided swollen leg, you could show it like this. You could show an actual picture of a patient with a swollen leg, and then you need to make the assumption that they have this particular pathology going on here, where you have, and this is important, you've got the right-sided iliac artery compressing the left-sided iliac vein here. So this is, you can imagine how easily this would be to make up a multiple choice question on this. Is it the left artery compressing the left vein? Is it the left artery compressing the right vein? Is it the right artery compressing the left vein? Etc. So it's the left leg that's getting swollen, so it's the left vein that's getting smashed. A vein can't smash an artery. An artery can only smash a vein because they're higher pressure, right? So it's never going to be a vein compressing an artery. It's always going to be an artery compressing a vein. It's the left leg, and just remember that they're switched. So left leg swollen, left vein compressed, and then the other one is the other one, so it's the right artery doing the smashing. Okay, so it's impaired drainage in the left common iliac vein from compression of the right common iliac artery. And you treat these by both lysing the clot and stenting because it's under compression, so you have to fix that. Here's another compressive type of physiology or pathology where you have compression of the celiac artery by the median arcuate ligament. And what there's 2 ways to show this. One is this, they call this a J-hook type of appearance, where it's very, very narrowed here and has this type of morphology. Or you could get really sneaky and show it in axial and see this like this line here. Probably have seen this a few times, just going straight down. That's how, if someone was going to show you this particular pathology, that's how they would show it on axial. It's much sneakier on axial. it would be way easier to tell what was going on sagittal. In fact, it would almost be too easy, therefore it might be more likely to see it on axial. So this is what's going on. This is a normal situation here, where this part of the diaphragmatic crus just lays gently right above the artery. It's not causing any compression. If it's slipping down low, then you're going to end up having it pinch off. And they can go all the way down sometimes and pinch off both the celiac and the SMA. Something like that, where it's actually hitting them both. So this would be a very extreme example. And as a result of that, you can get aneurysm development. These people tend to have abdominal pain. So a little bit of compression there does not mean that you have the median arcuate ligament syndrome. You just have a little bit of compression. But if you've got abdominal pain and weight loss, then you've got the syndrome. The other thing to know, this is probably the most testable point, is that if they would show you angiography, it worsens with expiration, which is very confusing for a lot of people because you think, take a deep breath in, your lungs expand, you'd think the diaphragm would go down, and that would cause the ligament to tighten worse, but it's the opposite. When you breathe out, it actually draws it tight back across your spine, and that's what causes the compression. So remember it. You can remember it because it makes no sense, or you can remember it as that when you're breathing out, it's actually drawing it back, and that's what's causing this compression. It's treated with a surgical release of the ligament. So here's a next step question. Okay, so when you see this, what do you think of next? That's the question. So this is an aneurysm of the popliteal artery. What, if I was going to ask you, what do you want to do next? Do you want to look in their head? Do you want to look at their chest? Do you want to look at their other leg? Do you want to look at their belly? What would you say and why? So the answer is to look at the aorta, because people who have popliteal artery aneurysms tend to have aortic aneurysms. The other thing to do is look at the other leg, because most of the time popliteal artery aneurysms are bilateral. And the last thing to do is look at their toes, because they're at very high risk. So if you were reading this study and you didn't mention that, you can be sued for lots of stuff. Obviously, you can be sued for putting your name on a report, basically. But you would be more likely to be sued if you did not mention the popliteal artery aneurysm, the saccular one, and they ended up having a threatened limb later on or lost their toes, because they're at high risk for embolic disease in the setting of an aneurysm, which makes perfect sense when you look at it. So this is this versus that, where we are comparing an angiogram versus a renal CTA. Now the orange one is the renal CTA. The finding is classic here. We've got beating of the renal artery, so that's FMD. But what am I showing with this angiogram? Looks like it's got some beating on it also, right? Right there. So this is if you haven't done angiography, which most people haven't, this is a thing that happens not infrequently. About 3% of the time on angiograms you'll see it. It's called standing waves, which is basically just oscillations and pulsations of flow that you're imaging real time. That it tends to affect the femoral artery the most. You can see it in the renals or the carotids. If they're going to show it, they're going to probably show it in femoral, because it's easier to see it like that. They're smooth. It's a periodic thing. Now, FMD, classically shown in the renals, but just like the previous case where I said, here's a popliteal artery aneurysm, where you're going to look next, you could do something similar with FMD, where if I said, here's FMD in the renal, where you're going to look next, the next place to look would be the neck. So carotid is the second most common location, and the third most common location is the iliac. So FMD is not just a renal pathology. You can see it in the iliacs, and you can see it in the neck as well. There are 3 subtypes of FMD. The only one you need to remember is medial. Medial is the most common. It's like 95%. Of course, they are predisposed to spontaneous dissection, and as I mentioned before in the renal modules, these are treated with angioplasty without the stent, whereas atherosclerotic osteal narrowing is treated with a stent. So this is another this versus that case. Let's get a zoom in here, where we've got circumferential wall thickening of a artery here. This is probably subclavian, maybe a little bit of axillary. And then that's the yellow. And then on the orange, I'm showing it at the descending thoracic aorta, and a very subtle finding involving the left subclavian, where if you look at the caliper here and compare it to the caliper there, there's a smooth caliper change occurring there. There's an incidental bovine arch as well. There, see that? Okay, so this is giant cell arteritis versus Takayatsu's, and the demographics are totally different. For gamesmanship, if you're given demographics, remember giant cell only happens in old men. If they tell you it's a 30-year-old, it's not giant cell. If they tell you that it is a 20-year-old, it's not giant cell. Old men, they almost always have an elevated inflammatory markers, CRP, ESR. You probably learned about this in medical school involving the temporal artery. It's also called temporal arteritis. It's a large cell arteritis. The gold standard is supposedly a biopsy of the temporal artery, but it also affects the area where you would wear crutches. Like if you broke your leg and you're walking on crutches, like the armpit area, like where the crutches go. And the way they remember that is old men need crutches to get around, so that your old man has a giant set of crutches, and that's the part of the vessel that's involved. Takayatsu's involves the aorta, can involve the entire aorta all the way down into the abdomen. It classically is shown involving the origins of the great vessels on the chest, but you can also see it causing aortic occlusion or near occlusion in the abdomen. It's a young Asian girl as opposed to an old white man. It's easy to remember that it's an old Asian girl because of the name is obviously very Asian-sounding name. Here's a companion case. Dynamic, up and down, and with the arms up, you're seeing occlusion of the vasculature here. So this is thoracic outlet syndrome. That's how it's always shown. Not necessarily with MR. It can be shown with angiography showing the same thing, but arms up, arms down, compression with arms up. And there's 3 different types of thoracic outlet. There's compression of the nerve, compression of the vein, and compression of the artery. Compression of the nerve is by far the most common, but the way that it's shown on imaging is either compression of the artery or the vein. When you're compressing the vein and there's a thrombus in the vein, there is this entity where they call it Paget-Schroeder, and because it has a fancy sounding name to it, that makes it highly testable. So Paget-Schroeder is thoracic outlet syndrome with venous thrombosis in the subclavian vein. The most common cause is the anterior scalene. You can also have a cervical rib. That's another thing to look for. And this is treated with surgery. If you have Paget-Schroeder, they have to lyse that clot, usually multiple times. So here is an outline of the great vessels with there's sort of subclavian coming across, axillary, brachial, in this direction bilaterally here. Takayatsu's tends to involve the central portion. As you come out a little bit further, this is the area that is compressed in thoracic outlet syndrome. And then out into the armpit region is where you have giant cell. And this is the way that I like to think about it if you're given no history and you're just seeing a vascular issue in the chest. So here are two different pathologies that are involving the occlusion, iliac occlusion or near occlusion. The one on the red, it's totally out, and the one on the orange, it's nearly out at places. But it could be, this same pathology could actually cause full-on occlusion. Now, you would say, well, how do I tell these apart? If you're asked to tell them apart, or you're shown this case and both of the main options are or on the differential, this is the strategy that I would use. I would say, this person's old. How do you know they're old? I can tell they're old because I see a little end plate spurring here, degenerative change in the spine. I can see that there's intimal calcifications there. Old people don't get that. This person looks young to me. Look how clean that spine is. That's a young person's spine. I'm seeing no intimal calcification at all. I'm inferring this person is young, so this person has Takayatsu's. This person is old, so this is just atherosclerosis. So this is your main options when you're dealing with aortic occlusion. You've got a fat female smoker, degenerative change in the spine, calcifications. That's how you're going to get your hints there. Versus a young female Asian who's got no degenerative change. And this tends to be a smoother, look how smooth this is. Like you can just, that just looks like a vasculitis, right? It's got that real smooth circumferential. It's involving the whole vessel all the way up here. There's nothing else that looks like that. So, Lariche, what does that mean? Is that just for atherosclerosis or what? So this basically means you have aortic occlusion, and there is a clinical triad which is highly testable. Your butt hurts, you've got leg pulses that are down, and impotence. That's the triad. That can occur secondary to Takayatsu's if you had a penis. It's more common in women, obviously. Or atherosclerosis, which is also actually more common in women to actually get full-on aortic occlusion. The penis limpness, though, is in the triad. All right, so this is a, remember I said to try to figure out where the bolus of contrast is timed to help narrow down the pathology. You can see that the bolus of contrast is timed to the aorta, and we've got a coarctation here. So here's some trivia about coarctations. There's two main types. You can have preductal or you can have postductal. Preductal types are seen in kids, so I think premature, preductal, infant, postductal, a little later on down in your life, you know, pre or for pre-K, preductal, post, after, later in life, adult. Here's a trick, rib notching. You think coarctation, you probably remembered from like step 1 or step 2 that has rib notching. But the rib notching spares the first and second ribs. It's seen later down, and the reason is because you've got costocervical trunk feeding those intercostal vessels off of the first and second. Later on down is when you're going to actually end up having to form collateral pathways because of the coarctation. So sparing of 1 and 2. There's an entity called pseudocoarctation. If you have a really tortuous looking aorta, sometimes it looks like a coarctation, but the difference between actual coarctation and pseudocoarctation is that there are no collateral vessels and there are no blood pressure differences in the arms or legs or anything like that. Nothing hemodynamically real. So what are the associated syndromes with aortic coarctation? If you were going to remember one, I would remember Turner's. And when you say Turner's, you should say aortic stenosis. The other thing to remember is Barry aneurysms. And I don't have as good of a way to remember that. But if you're going to only remember one thing, it would be Turner's. And then once you remember Turner's, you should say aortic stenosis. So this is a MIPT image, axial and coronal. And what you may have noticed is that there is this blob of vessels here, seen here also, involving the colon. It'd be really nice also if they gave you history of rectal bleeding or colonic bleeding. So the most common cause of bleeding from the colon is diverticulosis. This, depending on what you read, is sometimes referred to as the second most common cause. And it's a colonic angiodysplasia, where you have this tangle of abnormal vessels, typically on the right side of the colon. Left side of the colon strokes, right side of the colon bleeds. Left side has the splenic flexure, where you've got that watershed area between the SMA and IMA distribution. That's the part of the colon that would infarct. It's susceptible to ischemia. The right side of the colon is where you get angiodysplasia, and that tends to be where you bleed. The way that this is shown sometimes too is that you can show it on a MIP with a bunch of angry-looking arterial, like it looks like a big AVM, or they can show a big dilated draining vein. So there's a syndrome associated with colonic angiodysplasia. And in this syndrome, the number one thing you need to remember is aortic stenosis. So angiodysplasia gets aortic stenosis. All right, let's do a zoom up here. So we've got two cases showing an aortic balloon pump in different locations. This is the aortic knob here for reference. One of them, we've got the catheter down low, and then the other one, we've got the catheter up high. So which one's right? So where is this thing supposed to be? So the way to remember this is that it's supposed to be located distal to the takeoff of the left subclavian artery. You don't want that thing inflating and taking out your left subclavian artery over and over and over and over and over again. You can imagine that would cause a problem. So it has to be distal to that. So you want to see it down a little bit lower. So the way that these things work is you have they will inflate during diastole, so like this, and then as the blood goes through, it gets forced back into the coronary arteries and helps perfuse the heart. So it's down, and it's like, it's inflating as the heart beats during diastole. So it's not inflated the entire time, it's periodically inflating, and the purpose is to help drive blood back in through the coronaries. The thing you need to remember, though, as a radiologist, is where it's positioned, and it should be positioned distal to the takeoff of the left subclavian artery. All right, so this is the end of part 3, and the next lecture will be a multi-part series on the thyroid and parathyroid.